Hello and welcome to RCPsych Dean's Grand Rounds. I'm Deepa Bagepalli Krishnan. I'm a consultant psychiatrist and lead for the RCPsych Dean Grand Rounds. Today's Grand Rounds will focus on multiple long-term conditions in people with intellectual disability. Next slide, please. Next slide. So the Dean's Grand Rounds is a vision that's set by our Dean, Professor Subodh Dave, to bridge the evidence education practice gap. So these webinar sessions are organized and supported by Dr. Abdul Rauf. He's the chair of the Conference and Advanced Learning Committee, also called as CALC, and also supported by Jessica Letters, who's the head of the events at the CALC team, and her wonderful CALC team as well. So just each grand round is hosted by the RCPsych division and faculty, and this particular grand round is being hosted by the RCPsych Trent division and the intellectual disability faculty. So a quick recap on the format of the Dean's Grand Rounds. So here we aim to narrow the gap between education and practice by exploring a clinical problem using 4 different lenses. Catherine, if you can click the slide. Next. So as you can see, that the 4 lenses here are depicted in the picture. 4 lenses include the patient experience, the current academic evidence, data, and quality improvement approach. So the aim is to embed lived experience in a clinical education and to empower clinicians to explore the data sets so that this can inform the impact of the evidence practice gap. And using this understanding to then plan a change intervention to address this education practice gap. So we hope that you can apply the learning from these grand rounds in your own clinical practice and take back this learning to your own clinical settings. Next slide. So today's grand rounds will focus on the multiple long-term conditions, and multiple long-term conditions refers to existence of 2 or more long-term conditions in a single individual. We know that multi-morbidity or existence of multiple long-term conditions is significant, and it's rising more so in the aging population and in deprived areas, posing a healthcare challenge. So this session will particularly focus on the challenges in managing these multiple long-term conditions in people with intellectual disability. Next slide, please. So within this session, just running through the format, so the first speaker will talk about their own experience as a patient. So we have Alix Glazier, who's an expert by experience. And this is a pre-recorded session that we have. That's a conversation between Alix Glazier and Sarah Rabbitte. She's a learning disability nurse working at the Leicestershire Partnership NHS Trust. So we'll pause at this stage to take some questions for Alix and Sarah, and then we'll carry on with the academic evidence, which will be presented by Dr. Gemma Lewin. She's a specialty trainee at the Leicestershire Partnership NHS Trust, followed by understanding of what the data is telling us, and this aspect will be presented by Dr. Amala Jesu. She's a clinical director at the Leicestershire Partnership NHS Trust, and then the final bit, looking at local initiatives to drive changes to address this challenge. This is presented by Dr. Satheesh Gangadharan. He's a consultant psychiatrist at Leicestershire Partnership NHS Trust. So we'll aim to take questions again towards the end, and there will be a panel discussion as well towards the end. This session will be recorded, and we will take questions at 2 points, as I said earlier, after the first speaker, and then questions towards the end. Please post all your questions in the Q&A section at the bottom that you can see. And if your question is for a specific speaker, please indicate that as well. We will try and take as many questions as possible at those 2 different points in the session today. But because we have limited time, if we're not able to answer all the questions, we hope that we can answer these questions later on, and this will be shared as a PDF with the recording after the session. So at this point, I would like to welcome Alix and Sarah. So if the recording can be played, please.
Hi everyone, we are here today to do a presentation. It's about learning disabilities and long-term health conditions, an expert by experiences story, presented by Alix and myself. So Alix, if you maybe just tell people a little bit about yourself and the kind of work that you're involved in.
Okay, so I'm Alix Glazier and I do stuff for Decode.
Yeah.
And I'm a part of the Learning Disability Partnership Board, and I'm also a chairperson for the locality group.
Brilliant.
Yeah, and I also go to the wrestling.
Yeah.
And I work for Sue Ryder.
Brilliant.
As a volunteer.
Brilliant. In your work in the partnership boards, what's that all about?
Okay, the partnership board is we work with Leicestershire County Council to make stuff easy to read. We talk about different subjects, about keeping safe, all that stuff.
Brilliant. So getting things right for people
with
learning disabilities. Brilliant. So that was a bit about Alix. So my name's Sarah. I'm a learning disability nurse. Alix mentioned a minute ago the Decode project. So the Decode project is a research project, and it's about improving health outcomes for people with learning disabilities. And me and Alix is part of our patient involvement group. So you've done lots of work, haven't you, about giving us feedback to make the research right for people. And we've been working together for just over a year, I think. So quite a long time. And we've done lots of work about talking to people to get things right, I think, for people with learning disabilities, and what sort of things they need to know about, really.
Yeah.
So we just wanted to give you a bit of background, didn't we, Alix, about your long-term health conditions.
Yeah.
So if we start with, so you've got epilepsy,
I have,
you?
Yeah.
Do you remember, or you might not, but what sort of, how young you were when you first
10 years old.
Yeah, 10 years old,
Yeah. I can't remember many details about it, but my mum said I had a seizure at school.
Yeah.
Then I needed to go to the hospital.
Yeah.
The doctors did not know much about why I started the seizures, but I was diagnosed with epilepsy.
Yeah.
Then I remember they were called it petit-mal seizures, which is now called absent seizures.
Yeah.
When I was younger, I took medication to control my seizures. I still take medication every day and night. Which means I do not have the seizures often.
Yeah.
Because I was so young, I don't remember much about the epilepsy diagnosis. I can't remember the last time I had one. I had a seizure, which is good.
Yeah, yeah. That's useful. So a bit of background, and then if you give us a bit of background, so the other long-term health condition that you have is asthma, isn't it?
Yes,
so
it is, yeah.
A bit of background about that.
Okay. My asthma started when I was older, in my 20s. I am weaseling a lot. This could be happening at any time, not just after I've been walking, exercise. I went to see my GP and they diagnosed me with it. I remember doing a peak flow test, which is how the GP knew I had it. I prescribed inhalers which I use every day and night, and these help me to manage my asthma. I still do it when I get wheezy at certain times. I'm not very good noticing when I need my inhaler, and they often rely on people telling me how to use it. Yeah.
Good background then. See, they're both conditions that you live with every day.
Yes.
And they're long term, aren't they? So you'll probably have them throughout your life.
Yeah.
So in terms of living with those conditions, so having a learning disability and having epilepsy, what does it feel like to have epilepsy?
Sorry.
It's okay.
It feels weird because I have to take my grab sheet with me.
Yeah. And what's your grab sheet? What do you use that for?
It lets people know what to do if I have a fit,
Yeah.
if I have a seizure, and it lets people like my work know. And it's really, really great because the staff at home know what to do. Yeah, really, really great.
So the grab sheet tells people what they need to do.
Yeah, definitely.
If you have a seizure. I guess is it quite easy just to be able to give people?
Yeah.
And what does it feel like to have? What does it feel like to have asthma?
It feels really weird, but people know. The staff know what to do.
Yeah.
And a good example is like when I go out with my dad, he thinks like it's really weird because like my dad would go, Alix, can you just stop coughing? You know, and it's really weird, you know, but the staff really, really know what to do.
Yeah. So sometimes, people might think you've got control over it.
Yeah.
Actually, it's your asthma that makes you cough,
Yeah.
makes you wheezy and things.
Yeah.
Yeah, that's good to know. So, I just thought we'd mention it might be useful to mention a little bit about treatment then. So with your epilepsy, so you mentioned already that you take medication every day.
Yes, I do.
And you said that makes your seizures stop, which is good. Who do you see who checks your epilepsy for you?
I see the epilepsy nurse or doctor once a year, and me actually said to the epilepsy doctor or nurse, could you keep me on, because I think every 3 years or however many years they would not see a person.
Oh, okay. Yeah.
I might be wrong by that. And my support worker always comes with me to the place. And it's really, really good.
Yeah. So you feel like you need that every year? Like you said,
definitely.
If you've been okay for a while, they might say, "Oh, we don't need to see you," but you think you'd like
definitely.
to keep it. Okay. And what about your asthma? How often do you see somebody about your asthma?
When I need to. I always get a text from the GP. It's really good.
Yeah. So good checkups.
Yeah, really good checkups. Yeah.
Okay. So we thought it'd be useful, didn't we, to talk a bit about the support that you get for your health. So these are the things that help you to keep well and to keep on top of your appointments and things like that. So what's the most important support that you need with your health?
The staff come up and give me my tablets, and make sure that I have the tablets and and my inhalers, and it's really, really great.
Yeah. So that having people there, like you might not need them all the time, but having them to come in and just make sure that, like you say, you've took your medication, you've took your inhalers, that's really
good,
really helpful.
Yeah.
And what about when you go to your appointments, like your checkups? What's important when you're having your checkups?
The staff come in with me. Because if they wouldn't, maybe me would not know what the doctors or nurses are talking about.
Yeah. So having that staff member there.
Yeah.
Will they write down what like the nurses said?
Yeah, hopefully they would do. Yeah.
Yeah. So they write it down for you.
Yeah.
And then you've got that at the end of the appointments. That's helpful. Yeah,
Yeah.
That makes sense. And so I think what we wanted to talk about now, wasn't it? And I guess the most important part of us talking today was, as an expert by experience, you telling people what are the most important things, basically. Like, so if you've got a doctor or a nurse or a professional watching now today, if they were seeing a person with a learning disability and helping them with their health, what do they need to know? What do they need to get right? So we were going to spend a bit of time, weren't we, talking about what we call reasonable adjustments. So things that should be changed to make care right for people with learning disabilities. So should we talk about some of the things that you mentioned when we were talking about this?
Yeah. So easy read information like pictures, like the time on the appointment, basically the place on the appointment, so that if a person with a learning disability doesn't get that, basically, they would not know what where to go and everything like that.
Yeah. So if you got a letter from somebody, say from about your epilepsy or asthma, and it's not an easy read, what are the hard things about getting a letter like that?
I would say to the staff, basically, I don't understand that. That is not easy read. The staff at the hospital or doctors, would need to make it easy read, for people with learning disabilities or carers.
Yeah. So like you said a minute ago, it helps you to know what time you need to be at your appointment, what day you need to be there. So making it easier to
definitely
understand. Yeah, definitely. And then you've mentioned about your support going to appointments. What about when you have an appointment? Say like you're getting your epilepsy checked.
Yeah.
Sometimes appointments are only really short, aren't they? Because doctors have a lot of people to see. Do you ever get longer appointments, or do you ever feel like you need?
Yeah. If I need to, I would do. Yeah. Yeah. But where I used to live, they used to do longer appointments, but I'm not sure if they do it the new doctors, which is Rosebery.
Yeah. What's good about getting, if you do get a longer appointment, how does that help?
It's really useful because the doctor knows that you've got a learning disability and they understand you. Yeah.
So does it give a bit of extra time?
Yeah,
to, like you
does,
say,
yeah.
So you can understand
definitely,
what it's about and things. Yeah, they're really important things to know, aren't they? And then so we also thought it was important, didn't we, to mention care coordination, or basically how everybody in your life works together to join up that care. And we were trying to think about an experience where that's not happened, but it sounds like actually you've had
really good
care,
experience,
which is good. Like we were trying to think of examples, weren't we, like if you'd had to go into hospital and you'd got your medication changed, but we couldn't think of an example where that happened, which was a good thing, actually, wasn't it? But we were saying sometimes you feel like things can be a bit separate.
Definitely, yeah.
So like your appointments for your epilepsy and your appointments for your asthma, and then like a health check appointment. You were saying like you don't always feel like they are
together.
Joined up together, And so has it caused any problems, would you say?
No.
Or, so for you that feels
a lot better,
okay. But I think a big part of that, so we were talking about who would you say is your care coordinator?
It'd be the staff here.
Yeah. And can you tell us a bit about why they'd be your care coordinator?
Because I have a certain member of staff as my key worker, and she does all the paperwork with me and everything like that.
Yeah, yeah. And why is that? Why does that help with your health to have that one person that can do things like that?
Because if I remember rightly, that person's got asthma, and she understands what I'm going through with the asthma side. Yeah,
like on a personal level.
Yeah.
And like, why is it important to have that person though that tells other people things that are happening? How does that help?
Yeah. Because on the system, they have to put all my information down, and Sorry.
It's okay.
Everybody who's with me looks at that thing and goes, Alix would need this and everything like that.
Yeah. So because that information is shared, is that better than
Definitely.
You having to
tell them,
tell everybody that, and it kind of joins things a bit better, which sounds good. So we wanted to share as well a good experience that you've had with your healthcare in the past and why that was good. So if you want to share that good experience.
Okay, with the nurse, I have a text, and the asthma nurse knows me really, really well, and that's a really, really good experience. And she told me how to use the inhalers, which is really, really good.
Yeah. So that's good, like you say. So she knows you really well. So does she not have to ask you like the same questions like every appointment that you go to? And so with your inhalers, does she just tell you how to use them, or does
she shows me?
So she actually demonstrates it so you can see. And is that more helpful?
Really, really good. Yeah.
What's helpful about her actually showing you, do you think?
She showed me once, and I thought, well, there you go. You see, showing me like once or twice, you know, is really, really good. And instead of just going, Alix, you know, basically this is your inhaler. Go on your way and use it.
Yeah. So it meant that you could see how it works.
Yeah, definitely.
Yeah. So that sounds good. And what about, we spoke about, didn't we, like a bad experience that you've had with your health and why that was?
Yeah.
If you want to share that.
Okay. Well, I go to the dentist, and I have to pay £79 for a hygienist appointment, and unfortunately the dentist did not tell me that I have to pay for £79 until I had that last appointment. Yeah.
So that wasn't communicated to you like before the appointment or anything like that. So was it a bit of a shock?
Yeah, really a shock. Yeah.
And what do you think they could have done better with
To
that?
basically sent me a letter saying you're going to have to pay £79 as the price has gone up.
Yeah. So some sort of warning about it.
Yeah, definitely. Yeah,
that makes sense. So I guess at the very end we just wanted to leave some final thoughts about what the important things are for people to know about supporting somebody who has a long-term health condition or a learning disability. So what were your final thoughts, Alix?
Okay. To get the stuff right, be kind to people with learning disabilities. Sorry. To get to know the person really well, to get the staff trained.
Yes. Yeah.
And for carers to include the people.
Yeah. So be included, people to, like you say, be trained. So have some knowledge about working with people with learning disabilities, and being kind and understanding. I guess,
definitely.
As well. Yeah. Brilliant. Thank you very much.
Thank you, Alex and Sarah. I think that was really insightful to hear that experience, and thank you for sharing that experience, Alex. I think the key things that I picked up from that was, you spoke about the importance of personalized care. You spoke about the importance of having that support around appointments, and the summary of the key points that's being discussed in the appointments, and how it's important to have that joined up care and easy read information, bite-sized information that's provided to you. So thank you for sharing that. We have a few questions in the chat here. I think you spoke about the duration of the appointments, Alex.
Yeah, I did.
So I think a member in the audience has asked, what would be, what would be an appropriate time duration for these appointments? What would work well?
I would say double the amount of the time that doctors should give you and the nurses, because it's like I explained, where I used to live, the doctors and nurses would see you together, if you get what I mean, for the appointment. So it'd be double the amount the doctors would see you, and that was through the learning disability team. You would get that through.
So, like, if you're going to have a 5-minute appointment, it'd be useful to have it for 10 minutes.
Yeah,
so
definitely.
You're like doubling that time. You've got more time to. Yeah, that makes sense.
That's really helpful. Thank you, Alex and Sarah. I think we have a few more questions there, which are more appropriate to take towards the end, perhaps.
And I was just saying to Sarah that you could get your information via the Learning Disability Partnership Board, which is run via Leicestershire County Council, and through that's how I got the locality groups and the partnership boards via Leicestershire County Council.
They're good networks to talk about health
definitely.
and things like that, aren't they? So
that's really helpful to know. Thank you. So I think that kind of emphasizes the importance of joined up care there, Alex and Sarah. But thank you so much for sharing those insights with us.
About certificate. There was a question about certificate.
What was there? I didn't see that one. Okay, catch up on that one.
Thank you. So we'll now move on to the next speaker, and we'll take all the other questions towards the end. So we now have Dr. Gemma Lewin, and she's going to talk to us about the academic evidence around this area. So over to you, Gemma.
Thank you, Deepa. So yes, I'm going to be discussing the current evidence base for multiple long-term conditions in people with intellectual disability. But we will also be having a look at the general population, as well as people with psychiatric disorders, so that hopefully I can convince you that it is a really relevant topic for all of us. Next slide, please. So multiple long-term conditions are defined as 2 or more coexisting conditions in an individual. And you might also commonly hear the word multi-morbidity, which can be used interchangeably. It affects 1 in 3 adults globally. And unsurprisingly, this increases significantly with age. So it can be up to over 80% in over 85s. The prevalence tends to be slightly higher in females. And there's also a link between multi-morbidity and socioeconomic deprivation. So as you might anticipate, it's increased in the more deprived areas. Multiple long-term conditions are associated with poor outcomes, and that includes premature death, poor quality of life, increased health service utilisation, increased use of emergency services, longer length of stays, increased readmissions, and ultimately an increased cost of services as well. And it has been described as one of the most significant challenges faced by global healthcare. As recently as 2022, there was a primer published in Nature for the general population, which describes that there's still very little known about both the prevention and management of multiple long-term conditions. So that is perhaps going to give you a clue as to the level of existing evidence that we have for the psychiatric and intellectual disability population. Next slide. So considering what we might be able to take from the existing literature for the general population, looking at a systematic review of over 500 studies, thinking about multi-morbidity in the general population, we noticed that over half of the studies focused on only the same 8 common conditions, and actually 1 in 5 of all studies didn't consider mental health conditions at all. So that's telling us that there's a lack of consistency and inclusion between studies, where certain conditions are going to be overrepresented, and actually others, such as mental health and intellectual disability, are either underrepresented or not considered at all. So in order to attempt to address this, there was a modified Delphi study produced. And the Delphi study takes the opinions of both professionals and people with lived experience. And then there's a recurring round of surveys which attempts to achieve a consensus at the end. So the aim of this study was to try and make a list of conditions that could be included in the future research of multi-morbidity. And actually around 35 conditions were identified. But even with these 35 conditions, intellectual disability still remained unconsidered. So of course, there's no guarantee that in the future research would use this consensus anyway, but it does show that there's a deficit in the literature, and specifically if we're thinking about intellectual disability. Sorry, I can see a hand raised. Okay, I'll continue. So the guidelines for multi-morbidity really began to emerge in around 2015. So initially, intellectual disability was completely absent from the national and international guidance, and that includes the World Health Organization and NICE guidelines. Intellectual disability has now been added into definitions, but there's still no specific framework that has been curated either within the NICE management or otherwise. Next slide, please. And looking at a large population-based study of over 8,000 individuals with intellectual disability and comparing that to 1.4 million adults within the general population, we can see that prevalence rates are significantly increased. So 68.2% of individuals with intellectual disability had a multiple long-term condition. And not only are the prevalence rates increased, but people with intellectual disability are significantly likely to have a greater number of conditions which contribute to the multi-morbidity burden. As you might expect, this comes with greater levels of polypharmacy and the associated treatment burden with that as well. So prevalence again increased significantly with age, but for people with intellectual disability, it occurs at a much younger age, and the prevalence of multi-morbidity at the age of 20 to 25 is what you might expect in the general population at age 50 to 54. So the study found that the level of socioeconomic deprivation was not an independent risk factor for multi-morbidity, which again is contrasting to what we would find in the general population. So we know that the demographic of the individual with multiple long-term conditions is considerably different, but so too is the profile of health conditions, which might not come as a surprise because we know that people with intellectual disability are more likely to have a diagnosis of conditions, for example, epilepsy, visual impairment, reflux, obesity, and most mental health disorders. There's also disease states associated with syndromes such as Down syndrome, dementia, and thyroid disorder. Interestingly, some cancers, cardiovascular, and respiratory conditions are also less common, and it's thought that this might be due in part, at least, to the decreased uptake of smoking, alcohol, and substance misuse. So all of these differences are important when we consider why strategies that are already put in place for prevention and management in the general population may well not be as successful as we would like. Next slide, please. When we consider the profile of health conditions, comorbidity clusters are co-occurring long-term conditions that happen more often than we would expect. And clusters can further our understanding as to the nature and etiology of conditions that occur together. But it also provides us the opportunity to identify subgroups of individuals who might benefit from focused prevention strategies. So we can also begin to have a look at where there might be outcomes which are particularly poor for an individual when a group of specific conditions occur together. An scoping review held here in Leicester has identified 20 studies for intellectual disability and multiple long-term conditions. And actually, even out of those 20 studies, only a very small number, so I think it was three of these studies reported on clusters. So that really demonstrates the shortage of knowledge in the area. And there are also some factors that present as problematic within intellectual disability research and multiple long-term conditions itself, such as there was quite a number of studies which focused only on a subset of individuals with intellectual disability. And again, the example of Down syndrome and the associated disease states that we spoke about earlier. In addition to this, over half of the studies focused on people with a defined severity of intellectual disability. So again, it means that we're not getting a grasp of the entire population. Next slide, please. So as I alluded to earlier, this is not something that is just specific to intellectual disability as a specialty. And research shows that there is an increased prevalence of multiple long-term conditions for people with a diagnosed psychiatric disorder at around 38.8%. And it is slightly higher when you observe a population group of people with severe mental illness. Risk factors are fairly similar to the general population and includes increasing age, female sex and level of deprivation. But the profile of health conditions differs. So when you take a group of people who are aged under 75, who are in contact with mental health services in England, and then compare them to the general population, they have death rates that are 5 times higher for liver disease and respiratory disease, 3 times higher for cardiovascular disease, and 2 times higher for cancer. And again, there's very little that we know about cluster analysis. A meta-analysis of studies showed that results between studies vary, and actually it wasn't possible to come to any consensus about clusters. So the relationship between multiple long-term conditions and both psychiatric disorder and intellectual disability is very complex. And when having a think about the challenges that make an argument for tailored research and management for our patients, I can mention a few, but of course there's many, many more. So both groups face significant inequalities in the access to and management of health conditions, and premature mortality remains substantial for both groups. Notably, there's a high rate of preventable and amenable deaths. So these are deaths that could be avoided either through public health and prevention interventions, and those that could be avoided through effective and timely healthcare. So both groups are more likely to reside in areas of socioeconomic deprivation or have alternative living environments such as supported living and residential care, where main caregivers or care coordinators could be a variety of people. People with psychiatric disorder may have increased rates of smoking, alcohol use, and substance misuse, and again, less so in the intellectual disability population. But this all contributes to that differing profile of health conditions and difficulties when we're going to be using standardized public health strategies for all people. We know that there are increased obesity rates and inactivity levels, decreased adherence to medication, treatment, and care programs. Our patients are vulnerable to metabolic syndrome and other complications of psychotropic management, as well as the treatment burden of polypharmacy. We could also consider that many of our patient group are already primed, as they are already living with a chronic and enduring condition. So just one further health diagnosis is needed to tip them over into that definition of multi-morbidity, and then the considerations and implications that come alongside that. So we also have considerations individual to our patient groups, such as communication, sensory, and adaptive needs. And I know that Alex and Sarah were mentioning, the easy read information and the extended appointment times that are really worthwhile for people with intellectual disability. There also remains improvement for the development of patient and public involvement, as both groups are underrepresented when it comes to co-producing research, which is able to reflect what actually matters to them. And the delivery of care itself might be sensitive, so it may require considerations of things like trauma-informed care or just the consideration that sometimes we might be overseeing the care of people who have historically been or continue to be stigmatized by the services that deliver it. So I'm sure there's lots of different things that will have sprung to your minds as well. But again, I hope it's not difficult to convince you that there is a need for specific and evidence-based guidance. Next slide. So to summarise, at the moment, there is very little defined evidence when we're thinking about the management of multiple long-term conditions in an intellectual disability. And guidance should keep the multi-morbidity concept at its heart. So that's where there's a focus on the individual and the interaction of the conditions with one another and with the person, rather than a comorbidity concept where one condition is managed as the index condition and the others are thought about as secondary to that. And management requires a move away from treating conditions in silos. So multi-specialty communication is key. That might be between departments, across different levels of care, and as well between health and social care services. This relates to integrated care, and a review of care coordination is required to consider the patient journey as a whole. There's a call for more research to further our understanding of the nature and etiology of multiple long-term conditions, to define clusters, and to target high-risk groups. And we must consider the needs of patients within our specialty, and this should be driven by patient and public involvement. And finally, coming back to a phrase that Alix mentioned in her video, which is me being me, I think it's really important to remember that there is so much variability even within our patient population, and the need for that individualized plan and the knowledge and understanding of the person is really essential. So thank you, that is everything from me, and I shall now hand over to Dr. Jesu, our clinical director.
I think everybody could hear me now.
Yes, we can hear you.
Yeah. Thank you. Thanks, Gemma, for that presentation, and thanks to Alix and Sarah as well. So my presentation is just going to focus on the local data we have. But this is specifically for learning disability that I have. I don't have the general mental health data. So for colleagues from general mental health services, my apologies. But I'm sure we can learn a lot from the data we have in learning disability, because we all understand as psychiatrists that there are significant challenges for people with mental health problems in accessing, health services, physical health services in particular, and there is a lot of health inequalities. But we also know that in learning disabilities or intellectual disabilities, the problem is quite exaggerated because of the nature of the condition. Next slide, please. So the data I have is the most recent one I've got from the public health colleagues in Leicester. So it's a system called Aristotle system that analyzes data from GP practices. And we have a total population of about 1.15 million people registered at GP practices. So this is looking at the whole of Leicester City as well as Leicestershire as the county and Rutland. And one of the interesting factors here is the level of deprivation, because you might have heard from Gemma earlier, the how deprivation affects people with mental health problems and how it can actually exaggerate health comorbidities. And significant amount of people with intellectual disabilities, they live in deprived areas within Leicester. There is also a slightly increased ratio of men registered with learning disabilities in Leicester. Next slide, please. So This is just a brief look at the national picture, because we all know that people with intellectual disabilities have higher rates of both mental health and physical health conditions. And within mental health, it's serious mental illness like schizophrenia and bipolar and psychotic depression that's quite high in people with LD, but also conditions like dementia. When you look at physical health conditions, it's epilepsy, which is highly prevalent in LD, but also weight-related problems, both being underweight and overweight. And a lot of times we have actually found that these can even lead to early death, which has been picked up by some of our mortality reviews. And then there is also groupings for the cause of death. It might be worth mentioning here about the LEADER project. People within the LD field will be aware of a LEADER project, but for those of you who have not heard about it, it's basically it used to be called as the Learning Disabilities Mortality Review, and then it's the learning from lives and deaths of people with LD and autism as well. So it was rolled out as a pilot project in 2015, and then nationally it has been done since 2017, and more recently they've also started to look into people with autism, even if they don't have a learning disability. And the aim of the program is really to improve the care of people with LD and to prevent those early deaths from happening. And for Leicester and Leicestershire, we have our own LEADER program, and we are presented with data once a year. And there are a lot of lessons that can be learned as well from these reports. So from those reviews, we have identified that cardiorespiratory causes are still the most leading causes of death in people with learning disabilities. And in recent years, COVID has also been in the picture, and then followed by cancer and neurological diseases. Next slide, please. So this is looking at the local data, and you can see that the table is on the next slide, but I'll just briefly talk about the important points here. So for many conditions, we found that the rates of that health condition is much, much higher in people with intellectual disabilities. But for a small number of conditions, the rates seem to be slightly lower compared to non-LD population, but we don't know if there is a bias in terms of identifying these people, or it's just under-recognized in this population. Is something to think about. Next slide, please. So you could see that, where it is highlighted as orange, this is all the conditions that are present at higher rates in people with learning disabilities compared to people without a learning disability. And as I mentioned before, high blood pressure and COPD are the two conditions which have been recorded at a slightly lower rate than normal population. Next slide, please. So the most prevalent condition, I think our expert by experience also shared her comorbidities, and it is asthma. And as you can see, the rate is really high for asthma for people with intellectual disability. And this is followed by hypertension and diabetes. Although overall, comparatively the rates are lower, but still hypertension is a significant comorbidity in people with LD. And again, when it comes to mental health conditions, severe mental illness is highly prevalent. And these three conditions, so severe mental illness, hypothyroidism, and autism, these are the three conditions with the biggest difference between people with an intellectual disability and people without. So it just means it's very highly prevalent in people with intellectual disabilities. Interestingly, if you look at the data for autism, it says 4.8% of people with LD have diagnosed autism, and it compares to 0.2% of people without a learning disability. And again, it makes you wonder, there is a lot of work that needs doing in the neurodevelopmental side of things. And we know the amount of wait lists in autism diagnostic services, and the prevalence rates are much lower, and we have a lot of work that needs to be done in diagnosing these conditions, actually. Because if you look at the prevalence of autism within a learning disability service, I'm sure it's much, much higher. We are talking about 20 to 30% of population within learning disability services. Next slide, please. So again, this is looking at, so the number of people with intellectual disabilities who have 5 or more chronic conditions, and they've looked at this, and it is like 4 times higher than people without a learning disability. And similarly, people with a learning disability are 4 times higher at risk of emergency hospital admission. And this is, again, one of the reasons, reviews like Leader happen in a sort of, it's high on the agenda within the learning disability world. Okay, next slide, please. So the data tells us the level of comorbidity and the risk of premature deaths for people with intellectual disabilities. I wanted to finish my talk by sharing something positive that's happening within the Leicestershire region. I know if you remember Gemma's talk, when we talk about prevention and making things better for people with learning disabilities, and you can also include people with mental health problems in that. It is about partnership working, and this is exactly what has happened in Leicestershire. So in 2020, a partnership happened between the local authorities, NHS providers, commissioners, as well as experts by experience, with a commitment to transform and improve services for people with intellectual disabilities. And at that point, we were really one of the worst performing regions when it came to things like annual health checks. But we can now proudly say that we are in the top 10 for England and second in the Midlands region in terms of number of annual health checks completed. And one cannot emphasize the importance of annual health checks for people with mental health problems as well as intellectual disabilities. And again, through work done through Leader or mortality reviews, as well as STOMP and STAMP. I don't know if people have heard about that. So STOMP is stopping over-medication of people, young people and children with a learning disability. And STAMP is supporting treatment and appropriate medication in pediatrics. So it has been endorsed by our college. And this is, and again, all of this has happened in, post-Winterbourne View scandal and the transforming care, where it was found that people with learning disabilities were often prescribed medication without a clear indication. And also multiple medications were being used without any careful monitoring. So these are things very high on the agenda of the LDA collaborative. And they have introduced various subgroups focusing on learning from the Leader reviews every year. So that's where we are in Leicester. And I'll hand over to Dr. Kumar, who will present his research. Thank you.
Thank you, Amala. I hope you can hear me. I'm I'm going to talk about a research project which is happening in Leicester, aimed at multiple long-term conditions or multi-morbidity, because I've heard from the presentations that you had so far, multi-morbidity is a significant challenge. It's a challenge to people with learning disability. It's a challenge to people with severe mental illness. As you know, the comorbidity of physical health problems is much higher in people with severe mental illness, which are often not diagnosed, not treated well, leading to significant increase in mortality. So this research is a collaborative effort between our trust and 7 other universities, where I'm one of the lead researchers with another academic from Loughborough, Professor Thomas Yun. Can we move on to the next slide? We are trying to solve some of the problems related to multi-morbidity using 3 things. One is the power of big data. 2 is actually the artificial intelligence approaches and how it can be applied in practice. And the 3rd is combining the big data and AI power with the lived experience of care that people with learning disability and their carers have, as well as professional experts. So this research is a 2.5-year research project funded by the NIHR, has 4 main parts. Number 1, as I mentioned before, it's a big data. We have 2 databases. CPRD covers most of England, and SAIL data covers most of Wales. So we have the data of people with intellectual disability from England and SAIL. And then we are using artificial intelligence. Within the artificial intelligence domain, we are using machine learning predominantly, and we are using machine learning to identify patterns of multiple long-term conditions, as well as how these conditions evolve over time. And we are also using multiple long-term AI for other purposes as part of this research as well, particularly when you have someone with multi-morbidity. As you know, most of the clinical guidelines are written for single conditions, but the reality of our clinical practice is that we never come across single conditions. We often come across conditions that occur together in a patient, where the single clinical guidelines are not very helpful. So we are using AI to experiment a particular approach called computer argumentation, to try and see if we can actually combine 3 or 4 clinical guidelines to generate the right guideline for clinicians. So we are using AI in a different way. And then the 3rd component of research is not just the analysis, but we need to provide the information from the data into an interactive dashboard, which is useful for health and care professionals, as well as for people, patients and carers as well. And then we are combining the insight that we get from the data and AI with lived experience and professional expertise to develop recommendations on how multiple long-term conditions could be managed better, and how the care of people with multiple long-term conditions could be coordinated better. So that's in a nutshell is what our research project is about. Can we move on to the next slide? To talk a little bit more about actually how we use AI, the first part of use of AI is the use of supervised machine learning approach, mainly to identify combinations of conditions that exist in this population. So we would start looking at which are the 2 conditions that tend to occur together in individuals. I've just given an example of that, but it's not just these conditions. We are looking at actually a wide range of conditions. In fact, there are about 75 long-term conditions that we are looking at as part of this research. So once you identify the significant association between two conditions, we then look at how did those two conditions evolve? Did the condition B come after A, or did it start before A? So what's the directionality of that pair? And once you identify actually the significant association between two conditions and the directionality, we can put it together as a trajectory of conditions that may occur in individuals. Could you move on to the next slide? So you then get, this is again examples. I think our data, we haven't started using our data for this demonstration. So we get actually trajectory of varying length. You might get actually 3 or 4 conditions, and sometimes actually it can go up to 10 or 12 conditions. For example, I think in our population, people with intellectual disability, there are people living with 10 or more long-term conditions, which is a challenge. So you identify the trajectories. So you might come up with lots and lots of trajectories in our population. And then we use another unsupervised technique within machine learning called dynamic time warping to identify actually the similarity between these trajectories, to bring it together, to bring and cluster it together. I don't know whether you know what dynamic time warping is. It's often used for identifying similarities in sequences, very often used in speech recognition. Whether you speak fast or whether you slow, there are certain way you speak, and DTW is very good in identifying the similarities between sequences of different types. So we are using that approach. The purpose is to bring together a range of trajectories of long-term conditions as it happens in this population, and then we develop a patient profile. It's pretty similar to a concept that is used in lots of industry called persona, especially the user research. For example, they're developing a particular design or a product for a group of people with certain characteristics. So they will develop a persona and then develop the product to that. So in a similar way, we are actually trying to develop the persona of a group of trajectories. So if you identify that patient profile, then we can use that patient profile to say, this person with these conditions now is likely to develop this and these conditions over the next 10 years. And that's actually how it's going to evolve. And that knowledge is going to be very powerful. That knowledge is powerful in the sense we can use it to design interventions or treat patients ahead of time. Or plan their care ahead of time. Next slide, please. So I mentioned earlier, it's not just the use of the data and the patterns that we identify, but it's also important to develop the right dashboard or the right information to both professionals as well as patients and carers at the right time. So a group of researchers are looking at actually how we could design the dashboard, whether it is in the electronic patient records or something that can be accessed by the patient through web, which actually give them lots of information about how the conditions that they have at the moment may evolve into something else. Next slide. Okay, it's most challenging when you think of people with intellectual disability, because we feel if we can get it done for people with intellectual disability, it will actually be okay for a lot more people than people with intellectual disability, because they find it very difficult to understand data. So we need to look at the right way of visualizing the data, not just visualizing. Sometimes we may also have to use physicalization or even storytelling approach to present the information in a way that people can understand. So we have a group of IT experts and a speech and language therapist working together as part of our research to develop the right information dashboards. Next slide. So these are the 4 work packages. The final work package 4, is to bring together all the information that I talked about. We are interviewing people with learning disability. We are running focus group for both people with learning disability, their carers, and professionals. So we bring the professional expertise, lived experience, intelligence from the big data and AI analysis together to develop a framework to help clinicians, to help services approach multi-morbidity in a smarter way. And that is actually the part of the research that we are doing. We are halfway through the research. If you go on to the next slide, please. We have a website if you want to learn more about the research. There are a few videos there of people talking about the research, as well as some information there. And equally, I have given you the email address where you can write to us, and we can provide you more information. So what we are trying to do, we recognize multi-morbidity or multiple long-term conditions as a challenge. And we have developed a quality improvement or a research framework to answer some of the questions that are currently most difficult, and how we can actually answer those questions and then help services for people for the future. Thank you very much. I think that's the end of my presentation.
Thank you, Satheesh. Captain, I'm not able to start my video, sorry. Thank you. Thank you to all the speakers today. I think there was a lot of messages to take back from all the speakers. So I would like to thank Alix and Sarah to begin with, and then Gemma for presenting all that evidence, and Amala for the presentation on the data, which was really succinct and comprehensive. And Satheesh, finally, thank you for presenting the impressive project that you're undertaking in your trust. So I think for me, the key take, before we move on to the questions, the key take-home points for me is thinking about, I think there's 3 things that jump out, 3 words rather that jump out to me. One is personalized care, collaborative care, and lastly, I think what came out to me was the emphasis on the communication, how we communicate with these patients with multiple long-term conditions. So I think really helpful presentations today. Thank you. And I can see that, Satheesh, you have answered quite a few questions in the chat, but perhaps I have made a note of a few questions which would be helpful to address again as a panel, if that's okay. And I can also see Subodh on the screen. So if there's anything that you would want to add, Subodh, that will be helpful. So I think, first of all, I think there's a question to the panelists on what's the best way that we as psychiatrists can work with other specialities when we are caring for people with multiple long-term conditions, especially in ID population. I
start answering and see if others can join? I think, in fact, actually, I've typed the answer to this. My answer would be very simple. I think often when we see people in our clinic, we just focus on the conditions that we are focusing on. For example, they are presenting with depression, schizophrenia, or drug use problems, or a behavioral challenge, as in a learning disability clinic. So we just focus on that particular problem, and we often don't see actually the other conditions that they have. So the most important, the first step, being aware of the other conditions that the person has. So once you're aware of it, then as part of your assessment, seeing actually the needs in other areas, like the person may have a hypertension, or the person has diabetes, or a renal problem. Are they getting the right treatment for it? Are they getting the right support for it? So that's the next question. If they are not getting the right support, you can refer them, or you can flag it up to the general practitioner. And then when you decide your treatment, it's important to consider how does that treatment may affect, how that treatment may affect other conditions. It's important to be aware of that, I think. So in your management plan, just be cognizant that actually your condition, which is depression, is occurring in the context of a number of other conditions, and therefore the treatment that you're providing is not creating more problem for the patient, and it's not creating more interactions. So that's then is part of your management plan. So if you do that, and then equally important is actually you identify actually, patient is gaining weight, patient is developing hypertension, so you can give some lifestyle advices as part of your consultation. So as long as you can do these things, you're contributing to the management of multiple long-term conditions. So you're beginning to help the person to coordinate their care better. You're becoming aware of the other conditions. You're making sure actually the treatment that you're offering is not causing too much of a problem for other conditions. So that's how clinicians could contribute to the management of multi-morbidity. That's kind of my simple answer to a very complex challenge.
Thank you, Satheesh.
Quickly, Satheesh.
Yes,
It's
yes,
simple things like annual health checks, isn't it? Just checking with the patient or the carer or family member. When was that completed? And most places have learning disability liaison nurses based with GP practices, and there are also nurses based in acute hospitals. So I think depending on the region, it may vary slightly, but if there are people, nurses in that capacity, it might be useful to link up with them and joint work. And also our community nursing colleagues play a major role as well in really complex cases. They often get involved and help patients access some of these physical health appointments. And also they are part of a lot of multidisciplinary meetings where complex decisions are being made, including use of mental capacity and best interests. Yeah, thank you.
Thank you, Satheesh and Amala. I think there was another question on the role of care coordination, and I think the point they were trying to make there in that question was how can primary care and secondary care kind of work together in managing these patients. And that links in with there's another question that kind of links into the same theme. So they would like to know the thoughts from the panel about how the continuity of care can be improved by general practitioners. And they've just given an example of the news story from yesterday where a 67-year-old man with mild learning disability had a missed cancer diagnosis. So I think that kind of links into the same theme of how can we work together and better in managing these people.
That's true, I think. I think often when you have a complex problem, a typical answer to that problem is professionals need to be better aware of that condition, or we should actually have a coordination or a coordinator. But in real life, it's very complex. A GP who see a patient for the 5 times for 5 minutes may not have the right information at his fingertip when he or she is seeing that patient. So we need to look at actually, we are living in comorbidity era. We need to look at actually how are we designing systems to support clinicians and patients which can manage multi-morbidity in a better way. Our research is actually a part of that solution. NIHR, for example, which is a research grant body in UK, has actually dedicated quite a lot of money for multi-morbidity research. Use of AI is only part of that. I think there is more research happening around the country in UK on multi-morbidity. I also know that actually it's not just in UK. There are research happening in America and other Europe and other areas as well. There is quite a bit more thinking that we need to do to see, are we designing our services and systems which makes it easy for clinicians to treat people with multi-morbidity, as well as patients, are they getting the right information at the right time? to self-manage and support take part in their care as best as they can. And I think our patients, whether it's LD or severe mental illness, they have a particular challenge that is way and over the general population. Multimorbidity in general population itself is a challenge, but people with severe mental illness or learning disability, it brings in an additional challenge. So it's important actually to look at are we designing the system better? That's kind of my take on it.
Just to add, it's a really complex area, as Satheesh mentioned, and in intellectual disabilities, we often hear about diagnostic overshadowing, and it's, a lot of people are victim to that, especially when it comes to, these sort of people where things are missed because either things are attributed to their learning disability, or another aspect of care is a lot of people with intellectual disability, they struggle to cooperate as well with interventions, investigations. And this is a significant challenge. There is no easy solution, but again, it needs that sort of joint up working. And as Satheesh mentioned, clinicians having those extra eyes and ears for their patients and taking an interest for their patients. And a lot of work needs to be done in primary care level as well, because only a small proportion of these people are open to secondary care services. A lot of them are still being managed within primary care. So I think we need to do a lot of work on education, training, and upskilling our primary care colleagues as well.
Thank you, Satheesh and Amala, for that. I think there was another question about the role of neurologists versus, LD specialists with expertise in managing epilepsy, in looking after people with epilepsy in this population. So, any thoughts on that, Satheesh, and rest of the panel?
I think that's a very good question. I think that's a question that is often asked actually around the country and probably around the world, and there is no clear, simple answer to the problem. My experience is predominantly from Leicester, an area where I work. Neurology support works very well for lots of our patients with mild intellectual disability. But when it comes to more severe intellectual disability, where the epilepsy presentation may not be straightforward, and often there is a complex overlap between epilepsy and behavior or other mental illness, neurologists struggle. And some of my patients with that kind of problems, often I find actually they don't get a fair deal from the neurology service, and they often actually benefit much better from learning disability service, where learning disability psychiatrists we are, but we also have an interest in epilepsy. They get a much better service. But at the same time, we just need to be aware actually that we need to have actually a good working relationship with the neurology service, because there are things that we could use from the neurology. I think lots of areas, including Leicester, which Amala could probably talk more about, are developing joint clinics, which is actually run by learning disability psychiatrist and epilepsy nurse or neurologist. So we have a learning disability psychiatrist who have a neuropsychiatry background and has an interest in that area. He does joint clinic with an epilepsy nurse, and there is access to a neurology advice in that clinic. And I'm more confident in referring some of my complex patients to that clinic than to the traditional neurology. Whereas someone with a milder LD, I'll be more confident in referring that person to a neurology, a traditional epilepsy neurology clinic. So it depends on the person, and it depends on the services that you have around you.
And I guess in Leicester, since we've had that service set up, the joint epilepsy clinic, it's made significant improvement, I would say. And the moderate to severe LD patients with epilepsy, they can be often missed out, because we know neurology services are stretched everywhere. And when it comes to reasonable adjustments, they really struggle to accommodate these patients. And what we've successfully done using our specialist epilepsy clinic is, being able to offer those adaptations, and a clinician who can understand both aspects, epilepsy as well as the learning disability, and can also use medications in a much more sensible way. So I think we are going to be reviewing the service, and we should be able to come up with some data as well on how our epilepsy service is doing so far. Yeah.
Thank you, Satheesh and Amala. I think there's another interesting question on any special considerations for people with multiple long-term conditions in intellectual disability needing, inpatient care. I'm assuming inpatient care they mean in intellectual disability inpatient units. That's my assumption from the question. So what would be the special considerations for people needing inpatient care?
The number of inpatient beds for people with learning disability is reducing. It's happening nationally. We have much lower number of beds currently. As a result, what's happening is actually we end up having most complex patients with often actually very long list of both mental health and physical health conditions. It's a little bit like actually the frailty situation or a multi-morbidity situation in old age psychiatry. I am an inpatient consultant in Leicester. My patients on an average have 4 or 5 conditions. And mental health conditions associated with 2 or 3, sometimes even more long-term health condition. And the sad thing is actually when they come into the inpatient, they haven't actually had the right diagnosis or the right treatment for their long-term conditions for a very long time, because they were not accessing services appropriately, they were not following the treatment, and it was very difficult to do the investigations in the community, a whole range of reasons. So I had a patient presented with depression, admitted with significant behavioral challenges, but she had a diabetes where the blood sugar was going over 30 at the point of admission. So she wasn't accepting the right treatment for it. She also had a range of other conditions. I have a couple of patients with pathological obesity and multitude of physical health conditions. So the LD inpatient environment, sometimes I feel actually that I need to know more about physical health conditions than the psychiatry, which is where I'm trained on. So we have a GP working, providing us support and advice. So it is a complex group of patients that we have in inpatient. The number of beds are low, and it is significantly difficult to find a bed when a patient needs an admission. That's one of our frustrations, because patients, because of their complexity, they tend to stay with us for a long time, and we are finding difficult to discharge patients because they need to be discharged to highly specialist community placement. They not the kind of people often will go back to their previous placement or previous home. So that's the context of learning disability inpatient services in UK, I think.
Thank you, Satheesh. I think we'll take one last question if that's okay. And I think it'll be good to have Subodh and Rav add in to this question as well. So this is a question about actually teaching about learning disabilities and multiple long-term conditions in medical school. So any thoughts on integrating this as a regular topic in the medical curriculum? And additionally, I think this person has asked, Yajur has asked if any of the panelists are open to delivering talks at medical schools.
I think probably Subodh is much better placed to answer this question, but I think I'll just say this. I think it's high time multi-morbidity is integrated into medical teaching. I mean, personally, I think I am providing input to Leicester Medical School, but within my capacity, I'm happy to consider any other request. I'll hand over to Subodh.
Well, Satheesh, I think we need you to do more. I think that's the bottom line. No, I think totally agree. I think I was mentioning that in the chat as well. That I think whenever I do talks on general medical education, I mentioned this, that we teach psychiatry, we teach medicine as if people come purely with that medical problem. I think we forget that people come with comorbidities, and that is the norm. And I think we should really be asking hard questions of ourselves, our medical education, and our psychiatric education. Is it justifiable in this day and time when, vast majority of our patients, 80 to 90% of our patients will come with comorbid mental health, physical health conditions, comorbid substance misuse, and then to teach psychiatry without any skills in managing physical health and comorbidities. I think, is that sustainable? Is that the way we want our future doctors and future psychiatrists to be? I would say not. So certainly as a Royal College of Psychiatrists, we've taken the view that we want to enhance the skills of our trainees. But this is a question not just for us; it's for all medical schools and all healthcare professionals, I would say. So I'm with Satheesh on this one.
Thank you, Subodh and Satheesh. I think just in the interest of time, we had another question on research. Satheesh, I don't know if you want to add quickly to this. So I think people wanted to know if they were interested in participating in research projects like the one you talked about. What are the opportunities out there?
My advice would be, I think I'm not an academic. I'm an NHS clinician. I do research because I'm interested in research. And the way I go about doing research is, if I have a research question, something that I feel passionate about. For example, this decode research came from my thinking. I came across actually the concept of persona, which is very often used in industry. And I said, actually, why are we not using it in healthcare? So I then thought about, actually, how do I go about doing that research? So I approached an academic and said, no, this is my thinking. How do I do it? He gave me a few ideas, but he wasn't interested in that particular research. I then went to Loughborough. I had actually contacts with some of the academic there where I had done some research before. There were more IT people and system engineers. And I talked to them and said, actually, that you guys use this persona often, but I want to use it in healthcare. How do we go about doing that research? And coincidentally, at that time, NIHR has advertised actually a call for research using AI. And we went for a small development grant, which was around £120,000. 1 year. The purpose of that grant is to develop a bigger grant. So we used that 1 year to develop that research better. And then when we went for a program grant a year later, and to my surprise, we were successful in getting that grant. I wasn't very hopeful, but we got that grant. And that's how I got into this research. And I do small research all the time. I think the most important thing is to network with the right people. You look around the universities around you, identify academics who have interest in areas and link up with them. That's if you are an NHS clinician, that's the most effective way of doing a research. If you are a clinician working anywhere in the world, it's actually linking up with the right academics around you, because they can guide you and then doing the research. That's the right way.
Thank you, Satheesh. I think that's a really good point about, networking and linking in with people, and also, doing research that's grounded in our clinical practice. I think that's the key bit there, isn't it? So before I hand over to Dr. Rao to close the webinar, I would urge you all to fill in the feedback form, because we use this to continuously improve our grand rounds. And thank you everyone for your active participation. And once again, thank you to all the speakers. So over to you, Dr. Rao.
No, just nothing much to add. Just on that last point about the research, I think really Subodh and the college, we're all very keen to improve the research capacity and promote academic training in our psychiatric academic in our psychiatry training programs. So we recently appointed an associate dean to lead that. Professor Rohit Shankar is leading on that project, and also I understand there is a national priority to improve the research capacity. I think there are some comments on getting more trainees and colleagues to get involved in research. So that's a very good point. So I just say I really enjoyed this afternoon. It was great. And also we had a global participation and a very real special thanks to Alix. It's always we need to see everything from a patient's perspective, and that's our core business. So Alix really set the scene, and all the speakers, the research evidence, and what's really happening in the local area. So thanks everyone. And a real special thanks to Deepa for organizing this. And Deepa is the real driving force behind this, our Dean's Grants Round initiative. And there was a lot of comments about the global involvement. Again, as you can see, the next grant round is going to be the involvement from European division. So we're really keen to promote global networking and mutual learning. Whenever college talks about the global work, it's not about we teaching other people. It's about mutual learning. We're all globally, there are a lot of challenges and we're all facing similar problems. So it's about the sharing experiences and mutual learning. So, and also got a lot of learning resources at the college. So please look into college website, e-learning hub. So make use of all the college resources, and we're always welcome for any suggestions. And as Deepa said, please give your feedback on Dean's Grand Sounds and how we can make it even better. So thank you, everyone. So we're finishing on time. So have a very nice evening. I won't say evening, whatever the time, wherever you are across the globe. Thank you all. So please join us for the next Dean's Grand Rounds. And also thanks, Catherine and Charlie, for keeping us all going and doing all the hard work in the background. Thank you.